Hello, I'm Janice Karen, Director of Policy, Technology, and Innovation at the Massachusetts Health Data Consortium, or MHDC. Excuse me. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. If you'll go to the first update, please. So if it's a new week, there's a new regulatory thing. The Office of the National Cyber Director has put out an RFI on open source software security. This is done in conjunction with CISA, DARPA, NSF, and OMB. It's part of the National Cybersecurity Strategy that was released earlier this year. I believe we talked about that here. Comments are due by October 9th. This is a really interesting RFI because it asks four overarching questions and then, excuse me, it provides a list of like 15 to 20 areas of focus, types of software, types of use cases, different things like that. So the questions that they ask are which of these potential areas and sub areas of focus should be prioritized? Which are the most time sensitive or should be developed first? What are the technical, policy, and economic challenges that must be considered? And how do these apply to other domains? And how might your policy solutions differ? So I thought it was a really interesting RFI. For those of you who wonder why we're looking at open source software security, a large portion of software in use on the cloud right now is open source. There are definitely healthcare solutions and pieces that might be part of any health IT solution being used today that are open source. For example, the NCQA recently announced that their CQL engine is going to be is in the process of becoming open source. So it is unlikely in this day and age that any real solution IT solution doesn't have at least some open source components. A lot of the infrastructure used within clouds for containers and for different pieces for cloud management are also open source. So it does definitely directly impinge on health IT, and it's something that we will hopefully take a further look at. Any questions, comments, thoughts there? All right, then let's go on to the next update. So this one is interesting. CMS put out on Monday put out some draft guidance on Medicare prescription payment plans. So this was part of the Inflation Reduction Act, and starting in 2025, both Medicare Part D and Medicare Advantage plans that offer drug coverage must offer a payment plan option for participants where instead of paying upfront until they hit the deductible for medication or the maximum amount for medication, the amount is calculated and split across 12 months and paid evenly across the year, regardless of when the expenses occur. And so no payments for, so the way this would work is the person makes no payments at all at the pharmacy, and then they are billed for these payments monthly by whoever is managing their insurance. So a fact sheet and some draft guidance and a timeline for this process was released on Monday. They're accepting comments on the draft guidance through September 20th. And this is actually part one of the guidance. There will be a second guidance document that comes out in early 2024. Looking at the timeline, the idea is that they'll do this first draft of this guidance, take in comments, do another draft, sort of mostly finalize this guidance, and then start working on part two and do a similar process there. So this particular document covers a lot of ground. I have not read the draft guidance document. I think it was somewhere between 55 and 60 pages. I looked primarily at the fact sheet. And so among other things, it covers how to calculate monthly payments and different requirements for monthly billing, how the claims processing workflow should work, how the pharmacy charging requirements should work, how enrollees elect this, termination processes. That's not termination of coverage, but picking someone out of the monthly payments back to having to pay directly at the pharmacy. and participant protections. And then there's a bunch of data submission and notification requirements. So this is kind of interesting because it's a really different workflow than people are used to. And there clearly are different data requirements and different types of components. So we will take a further look at this at some point. You can find the fact, I recommend the fact sheet, which is shorter. It gives a really nice overview. And then the actual guidance, like I said, was fairly long and presumably much more complicated. Any questions or comments there? It looks like someone's trying to talk but having some trouble. All right, well then we'll move on. Excuse me. So another, there was some more court activity on the No Surprises Act dispute resolution process. On January, oops, that's a typo. The CMS raised the payer and provider IDR fees to $350 as of January 1st, 2023. Apologize for that. Before 2023, it was $50 per party, so that was a pretty significant increase. An August 3rd ruling disallowed the increase. And so what this is this is pretty fast, actually, but CMS has put out some guidance regarding how to handle the IDR fees based on this district court ruling. So what's kind of interesting is that any fees that were paid before August 3rd stand, there will be no refunds. But if you were billed and haven't paid it yet, you only have to pay the lower amount, which is kind of annoying. I would be annoyed if I were in that situation. So disputes that were initiated on or after August 3rd automatically revert to the $50 per party fee. Disputes that were initiated between January 1st and August 3rd for which the fee had not been paid must be rebilled at the $50 rate. And like I mentioned, this is true even if one party already paid $350 and the other one hasn't paid yet. And paper checks or electronic payments that are dated after August 3rd are considered not paid by August 3rd. CMS does not actually explicitly address. This guidance clearly came out pretty quickly. I mentioned I was surprised to see it so fast. And there's a little bit of a hole where it implies, but doesn't explicitly state that these payments need to be adjusted. So if an electronic payment was sent, I don't know if it's through the form of if you're supposed to do a full refund and rebill. There's no specificity around that, but and it's not even 100% clear. But but they do say the statement they make the dash bullet is a statement they make, but they don't actually go into the implications of that or what to do about those payments that might have been dated after August 3rd, but that are for the $350 amount. Hopefully that was clear. Any comments? Does that need further clarification? All right, if not, then let's move on. So on price transparency, CMS has fined 3 more hospitals, and they were actually fined in July. There's now 7 total hospitals that have been fined. The new fines range from just under $64,000 to just under, excuse me, $850,000. So they add up for some of them. Part of the reason why the larger fines were so high is that the violations dated back to 2022, and the fines are calculated on a per bed per day with a daily maximum. So if you have an entire year's worth of fines, even if it's a fairly small number of beds, that's a hefty sum. And if you have more than a handful of beds, it's a really hefty sum. So two of those fines, including one of the fines, including one of the new ones, are marked as under review. It's not clear exactly what that means, but CMS is starting to clearly starting to do more enforcement on hospital price transparency rules. You can find the official enforcement page at the link. And what's really interesting is that when you go to that page, there's a link that they're listed in date order. It's basically a table listing all the enforcement actions, and the date is a link to the actual letter that was sent that outlines all of the issues and how the fines were calculated and all of that good stuff. So there's actually a lot of interesting information about how they're doing enforcement if you dig into some of those letters. Any questions or comments there? All right, let's move on to the next slide. So ONC Lantern, which is the tool that highlights fire usage for ONC and MITRE, has put out a new report called Lighting the Way for Fire APIs Implementation Report. That's a bit of a mouthful. What it actually does is it focuses on two specific issues and some potential solutions. The first issue is how there are no standards for how endpoints are published. And the second one is how it can be difficult to associate an endpoint with the organization it services. So the proposed solution to the first one is having specific endpoint publication requirements using FHIR endpoint resources. That actually was integrated into the proposed HTI1 rule already. So that is already in process. And then the second part of that for number 2 is to have FHIR organization resources for each entity and have that be a FHIR bundle with the endpoint resources. So what you actually have is for a particular, you'll have a set of endpoint, you'll have one or more endpoint resources and all of the associated organizations. And inside those organizations, in theory, there's an endpoint property in an organization that will point back to the endpoint resource that's actually servicing that organization. And that will allow better identification of the actual organizations that are associated with that endpoint, because the name isn't enough, specific information isn't, a particular point of what's typically included in a list often isn't enough. So any questions or comments there? All right, let's go ahead and move on. So the NIH is standing up what they're calling maternal health research centers of excellence, and this is an initiative to support research to reduce pregnancy-related complications and death, and to promote maternal health equity. And it's a distributed project with 10 geographically disparate participants who have to share data. So interoperability is a big key component of the project. Johns Hopkins will be responsible for managing all of the interoperability components of the project, ensuring data quality across consistency across the project, collating the data, and then providing data science and data analysis. They don't, in this initial, this is sort of an announcement at a high level, so they don't explicitly discuss the interoperability or data requirements, but I'm hoping that more information will become available as this project stands up and we can get a sense of sort of the type of data that they're exchanging and how that's working, and use that to inform other things. So you can find the release about the centers of excellence, and certainly anything that promotes maternal health equity and reducing pregnancy-related complications is a good thing in general for getting all the data stuff. So any comments or thoughts there? All right, let's go on to the next slide. And I believe if you'll pause there for a moment. I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@myhealthdata.org. That email address is also on your screen.